Good afternoon and welcome to our second session of our four-part series this academic year, Urology Speaks. My name is Mohamad Allaf and I serve as the Executive Vice Chair of the Department of Urology at Johns Hopkins. Today's webinar is being recorded and will be made available if you would like to pass the recording along to friends or family who might have an interest in this topic. We are delighted to see that so many of you have tuned in to listen and participate, and I would like to thank our panelists in advance for their willingness to provide our attendees an opportunity to learn more about how our multidisciplinary teams make complex patient-centered care decisions. In the interest of time, I will not formally introduce each one of our participants today, but please know that the panelists' full bios will be emailed to you and are available on the Johns Hopkins Medicine website. First, let me start by describing what a tumor board is. Tumor boards provide a huge benefit to patients, though it is a process that most patients usually don't know much about. The purpose is to gather doctors from different medical specialties to discuss cancer cases, share recommendations, and determine the best possible care plan. Although tumor boards can be held to discuss any type of cancer case, often they involve patients who have exhausted the standard of care, those who are seeking new treatment options, or those with rare or challenging tumor types for which there may not be a singular standard of care. Our urologic oncology tumor boards at Hopkins meet weekly, have a specific disease focus, and are typically led by our first-year urologic oncology fellow who presents each medical case. It is a tremendous learning opportunity for our fellow, which helps fulfill a critical element of our tripartite mission, which is education. Any case that is discussed at Tumor Board usually has been submitted in advance by a clinical specialist who is seeking input on the most optimal treatment plan. Each case is presented by the fellow with a brief patient history, included related pathology slides, radiology scans, and is followed by an open discussion amongst the board. Participating specialists can include pathologists, radiologists, nuclear medicine specialists, urologists, oncologists, and radiation and medical oncologists. Today, our second-year urologic oncology fellow, Dr. Sunil Patel, will lead this tumor board. What you'll experience today is a special aspect of how we care for our patients. We believe that our intentionality around collaboration and teamwork across the institution is one of the differentiators that makes Johns Hopkins Medicine a world-class leader in clinical care, medical discovery, and education of the next generation of specialists. As you listen to our doctors discuss each case, please know that it is our dedication to patient-centered care that inspires us to ask challenging questions and work with our colleagues to create positive outcomes for our patients. And finally, please know that we have taken special care to remove all patient identifiers to ensure anonymity. After our 3 case presentations, we look forward to answering your questions. Please use the Q&A button at the bottom of your Zoom screen to submit a question at any time during or after the presentations. We will try our best to answer as many as we can. And now I proudly turn you over to Dr. Sunil Patel. Dr. Patel, the screen is yours.
Thank you, Dr. Allaf. We're going to get started with these 3 patients. Our index patients are a 52-year-old gentleman with a high-risk localized disease, the second gentleman with biochemical recurrence, and the third gentleman with focal therapy options. So in our first patient, As a 52-year-old gentleman who initially presented with gross hematuria with increased lower urinary tract symptoms on his gross hematuria workup. He was noted to have a PSA at 3.9 with an abnormal digital rectal exam, which prompted a prostatic MRI, which revealed a PIRADS 5 lesion in his left lobe with suspicion for neurovascular bundle involvement, as well as potential seminal vesicle and sidewall invasion. He had a 44 cc gland. He underwent a prostate biopsy, which showed that lesion showed Gleason 5+5 or grade group 5 disease greater than 90% of that core. The whole right side of his biopsy was negative. He underwent a metastatic workup given his advanced disease, including a bone scan and a CT scan, which showed no evidence of metastasis. Under a research protocol, he underwent a PSMA PET scan, which showed a primary prostatic lesion and a 7mm right upper lobe pulmonary nodule. Genetic testing was negative at that time. His repeat PSA was still 3.5. Of note, his family history was significant with uncles with prostate cancer at a late age and a mother with an unknown type of kidney tumor. Otherwise, his preoperative IPSS or his voiding symptoms were roughly 25, so moderate to severe lower urinary tract symptoms, and his SHIM, which is a marker for his erectile function, was 13, indicating moderate to severe erectile dysfunction. He underwent discussion at our prostate multidisciplinary clinic, and the decision was made to enroll the patient on a J1560 trial, which included androgen deprivation therapy as well as radiation. The androgen deprivation therapy was going to include 2 years of leuprolide as well as bicalutamide. He started his ADT, and on the research protocol was rebiopsied at Hopkins, which revealed actually small cell features of his prostate cancer. He was rediscussed at our tumor board, which the tumor board consensus was recommending continuation of ADT and radiation therapy, however, chemotherapy given his small cell features. He completed 4 cycles of his chemotherapy from December last year to March of this year. However, he was having ongoing hematuria, his lower urinary tract symptoms persisted, as well as horrible nocturia. He underwent a restaging physical exam with his digital rectal exam revealing a prostate that was relatively mobile, and underwent a cystoscopy, which showed no involvement of his ureteral orifices or prostatic involvement of his bladder neck, and his repeat PSMA showed resolved pulmonary nodules. If we can review our pathology or the pathology and radiology review.
Great. So this is the biopsy we received following his initial course of ADT. And it's a very unusual and very high-grade appearing tumor. There's almost no glandular differentiation in this tumor. You could see just sort of sheets of very blue cells here. And the blue is the nuclei of the cells, which is taking up most of the space within the cytoplasm or within the body of the cell. So the nuclei are very large. And again, no glandular differentiation whatsoever. Given the lack of glandular differentiation, we suspected that this might have some features of neuroendocrine differentiation, which is when the prostate cells sort of lose their identity, often because we've applied some selective pressure, such as androgen deprivation therapy. And so the pathologist examining this case looked first at a proliferation marker to see what fraction of the tumor cells are proliferating. In a typical prostate tumor, it's not larger than about 5% of cells overall. So actually a very low proliferation fraction compared to other types of tumors. But you could see here in this prostate tumor, all the brown cells on the left, all the brown dots are the nuclei that are proliferating actively, meaning dividing actively within this tumor. And so the proliferation rate, or the percentage of cells that are dividing, is probably 80% at least, which is very, very high and unusual for a prostatic adenocarcinoma. And that would be more typical of a neuroendocrine differentiated tumor. However, when we looked at neuroendocrine markers, so these are sort of neural cell markers that prostate cancer cells can begin to express, particularly after they're put under some kind of pressure like androgen deprivation therapy or some kind of treatment. We don't see any synaptophysin or any neural marker expression. So it's a little bit of a hybrid case. The proliferation rate or the rate of cell division is suggestive of some neuroendocrine or very, very high grade features, but we don't have a complete picture of neuroendocrine differentiation because the cells are not expressing neuroendocrine markers. So it was eventually signed out as a gleason 5+5 equals 10 or grade group 5 adenocarcinoma with a note suggesting that it might have some neuroendocrine differentiation and perhaps chemotherapy could be useful in that context. So in this slide, you could see his prostatectomy sample. And at this point, we have sort of a tumor with divided features. So on the left side, you can see tumor cells that are making some glands, some sort of circular structures or glands that resemble the normal prostate. So these are cancer cells that are better differentiated. They're adenocarcinoma cells. And on the right, you can see just sheets of very poorly differentiated cells. These still have overall more features of adenocarcinoma than neuroendocrine carcinoma, but this may have been, this area may be better related to that very poorly differentiated area we saw on the biopsy here, and may have differentiated after additional therapy. So this was again signed out as a 5+4 = 9 adenocarcinoma. And then this is just an example of seminal vesicle invasion that we saw in this case. So the case was pathologic stage 3B, meaning there was invasion of the adjacent seminal vesicle glands adjacent to the prostate. On the left, you can see with some brown pigment in them, the normal seminal vesicle epithelium. And on the right, you can see the cancer cells invading in the muscle layer around the seminal vesicle there. Again, these are adenocarcinoma appearing cells. There was also a metastasis in a lymph node. And so this was staged as P or pathologic stage 3B and 1 at radical prostatectomy.
All right, so we'll take a look at some imaging for this patient. He has both an MRI and a PSMA PET. And similar to the pathology, the appearance of this tumor is highly unusual on MRI. On the left-hand side of the screen is the T2-weighted or anatomic sequence, and on the right-hand side is a diffusion-weighted or more functional biological sequence of the MRI. And nearly the entire left side of the gland and extending outside of the gland is a heterogeneous tumor with a very odd growth pattern. So we don't normally see such obvious violation of the capsule around the prostate and growth of tumor in this fashion, all the way up to the sidewall of the pelvis. So a very unusual appearing tumor on MRI. In the right-hand image, what we're able to see is decreased signal on diffusion-weighted imaging. Admittedly, diffusion-weighted imaging is sort of the Rorschach test of radiology. You really have to sort of be honed in and be looking at something very specific to make anything out of all the sort of gray and white dots. But in the area where the tumor is, again, occupying the left side of the gland, there's relatively low signal, which indicates sort of tightly packed cells and is very suggestive of an aggressive tumor type. So can we move on to the PSMA PET? Perfect. So PSMA PET's a relatively new tool. It was the first PSMA radiotracer was FDA approved in the US in December of last year. And then an agent that's more nationally available was approved in May of this year. This was done on a research protocol. And most of what we see here is completely normal. So the lacrimal glands above the eyes, the salivary glands around the face all have normal uptake. The liver, the spleen, the kidneys, the bowel, all normal. And then there's excreted radiotracer in the urinary bladder. And then right below that, there's this fuzzier, less well-defined area of uptake. And that's the tumor in this case. On this whole body image, there's really no evidence to suggest that there's anything outside of the prostate. There's just the primary tumor. And we'll look at a few sort of slices through the pelvis on these images. And these are the PSMA PET fused to CT for anatomic correlation. And in the upper left, the bright spot there is actually just urine in the right ureter. And we see that again in the bottom right. There's really nothing else abnormal or nothing actually abnormal in any of these images. That is at least suggestive of this being a tumor that's confined to the prostate, although, as Dr. Lotan told us, there was pathologic evidence of disease in the lymph nodes. And in spite of how great PSMA PET is and how sensitive it is for sites of prostate cancer, it doesn't replace true pathologic surgical staging in these cases. And the sensitivity is relatively marginal for pelvic lymph node involvement. However, we can see there's very bright uptake in the primary tumor in the prostate. And this is also in keeping with the pathologic findings of this still being an adenocarcinoma. Neuroendocrine differentiated prostate cancers tend to lose PSMA expression and will not appear hot on PSMA PET. So this is additional evidence that this is at least somewhat behaving as an adenocarcinoma.
So in summary, we have a 52-year-old gentleman with initial diagnosis of grade group 5 high-risk prostate cancer, with initial decision to pursue ADT as well as radiation therapy on a research protocol. He was re-biopsied with which was significant for some evidence of small cell features. Now status post chemotherapy with persistent significant lower urinary tract symptoms with no evidence of metastatic disease and a negative cystoscopy for trigonal involvement.
So I would just comment that to give a patient this type of chemotherapy is not what we usually do for an average prostate cancer. Cisplatin and etoposide is reserved for patients we're very concerned about who have at least some indication of these neuroendocrine features. And as you saw from the pathology, that Ki-67 staining with 80% of the lesion, even though the synaptophysin was negative, made us concerned that this patient would have micrometastatic disease. And so we actually treat, when we worry about that, we think about using what's a regimen that's usually used for neuroendocrine lung cancer, and that's this cisplatin etoposide regimen. And we gave 4 cycles of that to try and shrink everything we could, even things we couldn't see. And it's interesting for us that it was noted that the patient had a small lesion in the lung that did go away on a subsequent scan, which suggests that might have been a metastatic foci that we treated with the chemo.
You know, we're learning so much about these PSMA scans, and Dr. Rowe, you've been a leader in that. But you know, this case is fascinating because typical prostate cancer is an adenocarcinoma, which you would expect to light up in a PSMA scan. Do we know yet, or are we still learning about variant histology within prostate cancer and how PSMAs do or do not detect that?
Yeah, great question, Max. And I would say that because these tend to be such rare tumors, there's not necessarily a big prospective clinical trial that's told us exactly how PSMA behaves in an imaging sense. Although at the pathologic level, it does seem as though most of these tumors will lose PSMA expression, and I think we'd expect them to be cold on imaging. And the small sort of retrospective case series and case reports that we do have are consistent with that, where we really we don't necessarily reliably image these with PSMA PET. Although again, his primary tumor was quite hot, so I do think that is suggestive of at least some maintenance of kind of the adenocarcinoma phenotype, or otherwise, again, we wouldn't have even seen it on the PET scan. As to whether potential metastases might be sort of more differentiated along a neuroendocrine phenotype, and we might miss them with PSMA PET. That's certainly possible, although I don't think we know that definitively yet.
Just to add a comment from the radiation oncology perspective, I think this is also a positive plug for research and considering research trials as part of the continuum of care. In this case, we have a trial that was designed for patients with high-risk prostate cancer who were considering radiation and hormonal therapy. And prior to it being, becoming commercially available, we had it available just under research, wanting to see if we could detect patients with, distant disease not being picked up on their conventional scans. But also it included this second scan and baseline biopsy and second biopsy, trying to assess response to hormonal therapy and see if there are some sort of correlates with imaging and biology. And in this case, I think it was helpful, hopefully had a positive impact on the patient's course. And it was that research biopsy that really detected the small cell differentiation and altered the course in advising, additional systemic therapy. And then later he was, kind of steered towards surgery, perhaps taking that into consideration, and also some of his response to the treatment and his sort of full course. So just wanted to add that comment as well.
Great. Thank you, everyone, for your comments. So the next case is a 70-year-old gentleman with biochemical recurrence. So he initially presented with a rising PSA 2s in 2014 all the way up to 7.8 in July 2015 with a 10% free value. His DRE was small and symmetric with no abnormalities. He underwent a prostate MRI, which showed a 41 cc gland. Again, no focal abnormalities, which was read as a PIRADS 2. Given his concern, he did undergo a prostate biopsy, which showed a bilateral high-grade pin. There's no really evidence of true prostate cancer, potentially a precursor. And then, however, in May of 2016, his PSA sharply rose to 20.2. His free PSA was down to 7.6, and his prostate health index was 96, which was pretty convincing that he potentially had some sort of clinically significant disease in this prostate. He underwent a repeat MRI, which actually revealed no change from his prior. Given the lab values, he underwent a transperineal saturated biopsy, which revealed 4 cores showing grade group 4 disease and 1 core of grade group 3 disease. Note, he had an excellent shim with no erectile dysfunction and no urinary tract symptoms. His family history was significant for bladder cancer. He underwent a bone scan and a CT scan, which showed no evidence of metastatic disease. He underwent a PSMA PET scan on research protocol, which was negative as well, and subsequently underwent a robotic-assisted laparoscopic prostatectomy with pelvic lymph node dissection in September 2016, which showed a path of T3B with seminal vesicle invasion, grade group 3 disease. However, given his T3 disease, he was followed with ultrasensitive PSAs. And you can look at this chart, his PSAs remain relatively stable post-operatively. However, around month 31 after his surgery, it started to rise to 0.13 and 46 months after surgery. He underwent a restaging CT scan and bone scan given his rise of his PSA, which was negative. His lower urinary tract symptoms were very minimal, and his erectile function was actually mediocre and actually quite well at 19. His pathology, we'll review his pathology and radiology right now.
Great. So this is a slide from his radical prostatectomy specimen. We're looking at a slide section through the prostate now. All of the pink is the muscle that surrounds the prostatic glands, and in the upper left-hand corner, in the upper right-hand corner, you can see normal prostate glands with some pink secretions within them. On the left-hand side, almost all of the epithelial cells that you see are tumor, and they're forming what we call cribiform pattern, Gleason pattern 4, which is when we see not a single lumen in the center or a single hole in the center of a kind of a circle of glandular cells, but instead we see multiple back-to-back small lumens kind of punched out, appearing like a sieve. Cribiform just means sieve-like in Latin. So this is cribiform Gleason pattern 4, and his overall grade group was grade group 3. So he was mostly cribiform pattern 4, 90%, and then 10% of the tumor was pattern 3. So it was 4 + 3 = 7. This is similar to a patient that we saw in the last case. This gentleman also had seminal vesicle involvement. On the left side, you can see the seminal vesicle epithelium and the lumen of the seminal vesicle, which is the white space you can see there. That's where all the seminal vesicle secretions end up. And then on the right side, you can see tumor just adjacent to that seminal vesicle epithelium. And again, more of this sort of cribiform pattern. So his overall pathologic grade was 4 + 3 = 7, 90% pattern 4 with some cribiform pattern. And he was on pathologic stage P T3B because of the seminal vesicle involvement, but he had no lymph node involvement, so he was N0. And the surgical margins were actually negative.
All right. So this patient underwent a bone scan and a CT scan, which is not surprising. These have been standards of care for patients with biochemical recurrence for decades. But in a patient with a low PSA biochemical recurrence, we'd expect both of these tests to be negative in more than 90% of patients. And the few percent of patients that they may show an unexpected metastasis, that's important, as it obviously is going to impact the patient's subsequent management. But again, the vast majority of these patients will have a negative bone scan and CT. Here, we'll start with this bone scan, and this utilizes a radio tracer called methylene diphosphonate, which just adsorbs onto the surfaces of bones. And anywhere there's bone turnover, there tends to be more accumulation of this agent. And we can see this in a couple of spots that are related to degenerative arthritis. So both shoulders, there's these bright spots at the acromioclavicular joints, which are degenerative. And there's also a spot kind of in the middle of the sternum, which is the sternum joint, which often has degenerative change. The right elbow is sort of where the radio tracer was ejected, and that's just a little bit of contamination. But there's nothing to suggest metastatic disease. And then where the CT really can be helpful is in identifying small lymph nodes or sites of local recurrence in the prostate bed. And here are a couple of representative slices, one through the pelvis showing sort of the obturator fossa and the internal and external iliac vessels, where we would often find nodes that would be recurrent prostate cancer. And then in the right-hand image is a part of the prostate bed, which shows kind of normal postoperative changes and no evidence of recurrence there either. So again, it comes as no surprise that these two tests would be negative, but they are important to do in case they do uncover something unexpected.
So in summary, we have a 70-year-old gentleman with grade group 4 prostate cancer, status post prostatectomy PT3B N0 with seminal vesicle invasion, negative margins, with biochemical recurrence with a slow rise in his PSA over years after his prostatectomy, PSA 0.13 with a negative CT scan and bone scan. And really the question is whether there's a role for a PSMA scan and also the role for salvage radiation.
Maybe the PSMA scan's the easier of the two, so I'll just kind of weigh in on that briefly. So most of our data with PSMA scans is in patients with PSAs of at least 0.2 in the postoperative setting. And the detection efficiency of PSMA scans between a PSA of 0.2 and 0.5 is about 50%. So about half of patients will have a positive scan and about half of patients won't have a positive scan. That's much better than CT and bone scan in the same setting where, again, we're talking about detection efficiencies in the single digits. So PSMA is really a remarkable advance in identifying sites of disease in these patients. And I guess from my perspective, probably the patients it's most important in are the about 25 or 30% of patients that are going to wind up having evidence of disease that's outside of what would be the traditional salvage radiation field, so that salvage radiation field can be adjusted or the patient can have alternative treatment. So I think PSMA is really important. Again, at this PSA level, it's not particularly well studied, but there's a decent chance that the patient would have a positive scan that may be helpful.
Before Kurt weighs in, I would just say that to the audience that PSMA scanning has been approved for biochemical recurrence now and will be used more and more as insurance figures out approvals and sites come online to do that. And I do want to emphasize that, Dr. Rowe was one of the major drivers of PSMA scans being approved in this country, and we should all thank him for that. And he also just recently published a paper showing that when you combine the rise in PSA, the speed at which it's rising with the absolute PSA value, he can predict pretty accurately who's going to have a positive PSMA scan and who's not. I'll stop there and turn it over to Kurt.
No, I think those are all important, great comments in how we think about salvage radiation and kind of planned salvage radiation. I think often folks are thinking that, if you don't have a positive scan or something visible on the scan, that means you don't treat, which, I think Dr. Rowe articulated well that really we're just looking to see if there's something that alters the management that might help us adjust the field or take that into account. But most likely either we're not going to see anything at very low PSAs, or we're often going to see something which is within the field that we were going to treat. So it's sort of somewhat reassuring from that perspective. So in this setting, it's fairly straightforward in the sense that the patient is a candidate for salvage radiation. We know that men do well when we essentially treat the prostate bed, the space where the prostate was removed, or the prostatic fossa. And there's somewhat of a debate in our field, ongoing studies, whether we also include the adjacent pelvic lymph nodes, but we'll tend to treat those, especially for patients who are high risk at baseline, like this patient was with seminal vesicle invasion, a high initial PSA, that they're still at risk for that micrometastatic disease within the lymph nodes. And then there's also a question of whether we include hormonal therapy with that salvage radiation, often what we call short course, so 6 months of testosterone suppression overlapping with their radiation treatment. And there's a few studies that have shown some benefit to doing that, although we're still trying to refine, again, what features, risk factors, Gleason score, or location of disease, are really indications for that. And then also, I think an additional thing to consider, we can use genomic studies. The Decipher score is an example of one genomic classifier, which gives sort of a risk score of the tumor. And there is data that men who have a high-risk genomic score, do better when salvage radiation is applied earlier, sort of closer to adjuvant as opposed to a late salvage. So those are just some of the considerations when we're evaluating for salvage radiation and the timing of when to proceed.
Thank you, everyone, for your comments. We'll move on to the third case. It's a 72-year-old gentleman. Initially, in 2015, was worked up for lower urinary tract symptoms. His PSA was 4.9 at that time with a normal digital rectal exam. He did undergo a prostate biopsy given his elevated PSA, which showed 1 out of 12 cores positive for prostate cancer, low risk with grade group 1 disease, 30% on his left side. And he was counseled and the patient elected to go on active surveillance. He underwent a confirmatory biopsy, which showed again 1 out of 12 cores, the same region on the left side, grade group 1, 30% of that core. His MRI was notable for a large gland, 73 cc's, no other obvious lesions. His PSA started to trend slightly up over the years, and in April 2019, underwent a repeat biopsy given his PSA up to 8.5. His prostate biopsy revealed 2 out of 12 cores on the left side, again, left apical area with grade group 2 disease, so upstaged, as well as left mid gland, grade group 2 with 10% of the core. His IPSS score is 25, so notable for moderate to severe LUTS, and however, no evidence of erectile dysfunction. He had no other familial contributory history. From April 2019 to February of this year, he underwent decision-making with consultations with radiation oncology, as well as second opinions of given his upstaging from grade group 1 to grade group 3 disease. He underwent a repeat MRI, which showed an 100 cc gland with the Pyrites 3 lesion on the left side. His pathology first.
Great. So this is from his second biopsy where he was upgraded to grade group 2 prostate cancer. And this case is actually a beautiful illustration of the pathologic differences between grade group 1 and grade group 2 prostate cancer, and is very straightforward in that sense. So here, in contrast to the other cases we looked at, which were radical prostatectomy samples, we're looking at a prostate biopsy, a needle core biopsy. And so you can see it's a long, very narrow, small piece of tissue, just a very small sample of the prostate. Again, the pink is the smooth muscle, which is making up most of the bulk of the prostate, and the blue lines and sort of circles that you see throughout are the epithelial cells. That's where we're really paying attention and trying to see if those cells are tumor. Most of the tumor in this core is on the right side, at the very far right part of the core, where it becomes very thin. And you could see even from low power, it looks more cellular in that region. It looks more blue. So if you go to the next slide, we'll look at a higher power view of that right-sided area. And you could see on the very far left of the slide, so the left part of the core, we see small sort of circular glands with little white spaces in between. The white spaces are the lumen. That's where a normal gland would, and even a cancer gland will secrete some secretions from the epithelium into that space. That's why it looks like a space. And these are pattern grade group 1 or 3 plus pattern 3 prostate cancer glands, because they make normal lumens like normal prostate glands do. On the right side, or on the very far right side, you can see areas of sort of blue cells that are just making sort of solid areas or cords of cells where we don't see any of those white spaces, those lumens, and that's Gleason pattern 4 prostate cancer. So those tumor cells are starting to de-differentiate, to sort of forget that, how to make a lumen the way a normal prostate cell does. And that's a very signature change that we see in Gleason pattern 4. The next slide is just an additional core from this patient. In this case, the cancer is predominantly on the left side, which you can see looks a little more blue and cellular. And if we go to the next slide after that, we can see a higher magnification view of an area of cancer. Again, this is a beautiful illustration of the difference between grade group 1 and grade group 2. So or I should say Gleason pattern 6, or Gleason pattern 3 and Gleason pattern 4. So on the left side, we see an area of Gleason pattern 3, again, where we're making round glands with clear lumens. And on the right side, you can see that you no longer have those lumen spaces. They're very small. The glands are forming sort of small cords of cells. So that's Gleason pattern 4. So this was overall a 3 plus 4 equals 7 tumor. So there was more pattern 3 than pattern 4 in this tumor.
All right, and here we have the patient's MRI, and as would be suggested by the pathology, with a relatively low grade tumor, this is where MRI struggles a little bit to actually define exactly where the tumor is and to what extent it's affecting the gland. In the image on the left, this is an image actually up through the seminal vesicles, and the right seminal vesicle, the left side of the image, are these sort of bright tubular structures, and that's what the seminal vesicle should look like. The patient's left seminal vesicle is diminutive, rather darker in signal, and looks to be very atrophic. That is not in and of itself a particularly specific finding, but it might sort of draw our attention to the left side of the gland, and we'll at least pay particular attention to that to see if we can see something like a tumor at the confluence of the seminal vesicles that may be impacting one of them. The image on the right is sort of an image that's taken through the middle of the gland, and almost the entire gland is benign prostatic hyperplasia. So the gland is sort of distorted. There's this very heterogeneous look to it, and it's fairly enlarged. So this is consistent with some of the patient's clinical presentation. As to exactly where the tumor is, quite honestly, I don't think it's very convincingly shown on the MRI. We can sort of probably squint and find something that would correlate to the pathology, but quite honestly, it's not necessarily something we would prospectively call on the MRI.
Thank you. So in summary, we have a 72-year-old gentleman diagnosed with prostate cancer, low risk in 2015, originally on active surveillance with a PSA rise, recent biopsy in 2019 with upstage to grade group 2 disease in 2 cores, all left-sided, who's very interested in focal therapy options. So the question for the tumor board is focal therapy options and recommendations based on the guidelines.
Yeah, so this is a common patient that we see. I think it does a number of things. It highlights how we approach active surveillance. This patient's been on active surveillance for more than 4 years, and that means that for those 4 years, their quality of life was not impacted by an intervention for their prostate cancer. So there was net benefit to this patient. And now there needs to be a time for shared decision making. There's a couple factors here that play into the decision that the treatment that the patient will make. Active surveillance isn't necessarily traditional for grade group 2 disease in 2 cores, but it's unilateral, and it's a very reasonable approach for this patient if they're willing to understand that there's a small, unlikely, but small risk of cancer progression. And then focal options, are also available to this patient. And we have several options, here at Hopkins that we would discuss, but most notably focal cryotherapy or whole gland cryotherapy could be considered. And then, radiation is also an option to this patient. I don't know if Dr. Deville wants to comment on the patient's gland size as impacting sort of the decision-making regarding that.
Yeah, definitely. Thanks, Dr. Case. So he has a number of radiation options. And, I think as we're sort of thinking through all the options, each one sort of has its pros and cons, and that can kind of make the decision-making tough here for a 72-year-old guy with favorable intermediate risk, sort of just aggressive enough, but not too aggressive. And so you're trying to balance all of these risks in terms of the side effect profiles. From a radiation standpoint, if we're going to do radiation, we would usually do external beam radiation and not an internal brachytherapy. Internal radiation, given the gland size, he kind of exceeds the limits, whether we're using prostate seeds or the alternative, less commonly done, but catheters can be placed for temporary radiation. And those are not good for men with very large prostates. There tends to be more local inflammation, swelling, irritation, and complications. And from the external beam standpoint, then he would have kind of conventional radiation with IMRT, with photons, or we also have proton therapy available. They're delivered the same way. Historically, it's 8 weeks, daily, Monday through Friday. We also have now accelerated courses of radiation have become more standard, so we can get through the treatment in usually 5.5 or 4 weeks is kind of the fastest mild acceleration. And then there's also stereotactic body radiation treatment, which is 5 treatments, usually every other day, which a little bit of controversy, but we tend to steer away from men with similar to the brachytherapy considerations with very large prostates, and they tend to have more local urinary symptoms. And so an aggressive dose regimen may be potentially a little bit more risky in that setting. But those would be his radiation options to consider, as well as even surgery, I guess, if he's interested in that as well.
Perfect. Thank you, everyone, for your comments.
Great. Well, we are going to go to the Q&A portion of this. Does anyone have questions? Please go to the Q&A at the bottom of the Zoom. Here's a question. Dr. Pienta, maybe you can shed some light on this. What happens when there's disagreement on the tumor board?
I win. Well, what else do you need to know?
The rest of the question is, if there's a strong personality that is dominant.
There's often disagreement, right? We bring cases to the tumor board because they're complicated. And really, it's a sounding board for all the disciplines to get together and think about how to take care of the patient best. And we're often at the cutting edge of medicine where there's not a standard of care that necessarily we know that we can just reference to follow. The important part is we discuss it and we say, well, radiation could be an option. Let's talk to the patient. Surgery could be an option. Let's talk to the patient. Let's let the patient weigh the pros and cons after we have weighed the pros and cons together.
Great. Thank you, Dr. Pienta, for that. Another question we got is, do patients ever attend these, and can they?
So you're still on mute there.
To the panelists at large, it doesn't have to be you, Ken.
Okay. Max, do you want to take that one?
Oh, okay, sure. I think patients haven't in the past. I think it'd be an interesting study in and of itself to see how patients being there impacted the tumor board in any way. It's a very interesting question. I haven't thought of it before, to be honest. Usually the way that these tumor boards run is we actually presented 3 cases in an hour. Typically we'll present up to 8 to 10 and so things are moving very, very quickly. But that's not to say that that there's. I think it's an interesting question, and I'd be interested in doing that experiment. So if the patient's interested, have them contact me and we can talk more.
I mean, I can just add, I think that the multidisciplinary clinic, may be a similar but kind of alternative format where you may, have more of that patient engagement in that the patient comes in, you have all of the specialists. We still have sort of the conference separate, but then you'll go back to the patient, and often, you'll have multiple providers that are then kind of sharing. And so I think you have more of that engagement. So sort of a plug for the multidisciplinary clinic context as well.
It's a great point too.
There are some, sort of specific medical questions, but I suppose we could take those. Was it too late for the 52-year-old patient to have a radical prostatectomy? I think this was our first patient that was discussed in the tumor board.
So that patient, I believe, ended up having a radical prostatectomy. It was a little confusing. We apologize the way we presented it, but actually the patient was originally on a radiation therapy protocol. And then because of that follow-up biopsy, we actually treated the patient with a radical prostatectomy and the chemotherapy. And that's where this kind of intervention with the tumor board really made a difference, because that there is no standard of care for that patient.
Thank you for clarifying, Dr. Pienta. Maybe this one's for Dr. Lotan. How often do you see equivocal surgical margins post-prostatectomy, and how is that reconciled?
Yeah, that's a good question. I would say rarely here are margins equivocal. I mean, the way the surgical margin is delineated, we ink the outside of the prostate. So we have ink on the slide, we have ink on the outside edge of the tissue on each of the slides. I don't think we had an example in these current cases. And then we evaluate whether we see tumor touching that ink. There are some situations where we get artifacts in the way the sample is cut. Sometimes we can't see the very edge of it because the tissue is kind of wrinkled in the block, and it becomes very difficult to get all of the edges in a single slide. But I would say that's quite rare. Usually we can see if the tumor's in the ink, and then we can additionally see if the tumor looks like it's been cauterized or affected by where the surgeon was cutting there. So we have kind of a two pieces of evidence to suggest that some tumor was cut and some may be left in the patient.
A couple of questions related to follow-up. One is, does the tumor board become involved in cases after the immediate plan of care has concluded, if some form of the tumor reappears? And there's a couple of other questions related to sort of follow-up that the tumor board members who made the decision, do you guys gonna get re-involved and follow the patient longitudinally? Can maybe Dr. Rowe give us a comment on that, and anybody who wants to comment.
Sure. I think that that's actually a really important aspect of tumor boards, is that we all make it a point to sort of ask each other to provide follow-up on what happens to the patients in terms of the decision making, and how their outcome may have been impacted, and what we can learn from that in future decision making. So it is so I think there are probably patients that just have a spectacular outcome and never have any other issues again, and they never sort of pop back up at tumor board. But there are patients that have sort of ongoing complexity that we wind up discussing on multiple occasions.
Yeah, I would say that, you know, being a participant in these at times, we see many patients who are presented longitudinally in this, and it's constantly sort of this multidisciplinary, because if they were complex at one point and the cancer journey is continuing, it remains a multidisciplinary kind of case that we all kind of take ownership in. How are results conveyed to the patient is a question.
Well, that I'll take one stab at that, and then maybe Kurt and Max can weigh in. But you know, I think people often wonder, how does a case or a patient get presented at tumor board? And really, that's cases are brought by us. I mean, we recognize that we have a patient that doesn't fit into a normal treatment paradigm, and we want to know, get help with that patient. And so we bring the patients and present them. Sunil presents them. And the idea is that then we often tell our patients, we're going to present you to our colleagues. And then it's our job to go back to the patient and say, collectively, this is what the folks thought should happen.
This is just so many great questions coming out. One is about, you know, there's a lot of mention in the tumor board of patient and tumor, and it's likely that there's an admirable attempt, at least, to sort of solve the cancer problem. Does the discussion ever identify the person as a person? In other words, socioeconomic status, are they able to come in for treatments? Are they able, you know, to, and I know the answer to it, but because these are such, you know, scientific, you know, but can somebody comment on this human side of medicine that we think is so important, of course?
Oh, yes. So I would say every case, these issues come up. Taking care of patients is taking care of humans, and every human is slightly different from the next, and so they come into every single discussion in some way. An example of a common case that comes up in that we didn't discuss today is the patient that, for various reasons, you know, the standard of care may be one thing, but the patient wants, you know, a different route. That happens all the time. It happens in bladder, prostate, kidney cancer, all the different types of malignancies that we treat. And our answer is never, we try never to, it's never going to be no. It's going to be, okay, well, this is now outside of sort of my normal paradigm based on the sort of the patient's desires. What can I then bring that's going to be an effective alternative therapy? That's a very classic tumor board discussion. So that's kind of an example of sort of where it's the patient sort of, you know, coming to us with, you know, their needs, and us responding with a tumor board.
Thank you, Max. Do doctors do informal tumor boards in their normal practice, and this is just a more formalized process? I would say yes, but I'll let the panel talk about this. And how did these tumor boards formalized come to be?
Maybe I can take a quick stab at the first part of that question, in that I'm typically in a dark room in a basement reading scans, but I really value when my frontline clinical colleagues come by the reading room and we have a chance to discuss patients in sort of a real-time setting, and pull up the images, and I can point to things and they can point to things, And that's actually a really valued part of my practice as a radiologist is having those discussions. I learned tremendously from them. Hopefully my colleagues also get something out of that experience. And so that would maybe be an example of just sort of an informal tumor board that kind of just coalesces at different points during the day.
Yeah, and while, I'll comment on this, while I can't tell you where the formal tumor board came from, but this concept of multidisciplinary kind of care is very ingrained in the Hopkins model or the Johns Hopkins model of what we do, the co-localization of sort of, different specialties next to each other, the collegiality amongst the groups, it's sort of ingrained by the sort of founding fathers of Johns Hopkins and forefathers, I guess, to sort of do this. So it's really in the culture of our place, but it's luckily been now permeating a lot of other places to do this.
I just add one other thing, Mo, like for the first case, for example, actually the first case we presented, the surgeon contacted me by email and we had a whole discussion about that case because there was some question of whether in the radical prostatectomy, there was some rectal tissue involvement, and we sort of went back and forth, even taking some microscopic images, which I shared with him. So we definitely did that kind of offline tumor board.
Yeah, I think this happens daily. This formal process, a few questions about, are all patients reviewed by the tumor board? And the answer is no. It's either triggered by a physician and some patients who can ask, to be included in this. So it has to be triggered, and usually it's reserved for more complex cases or nuanced cases. But this informal tumor board, I think, happens on a daily basis. Probably all patients get a form of it because I'm constantly calling Dr. Lotan or Dr. Rowe and Dr. Deville and Dr. Pienta. I'm going to call you right after this meeting to ask you a question about something. Maybe we'll take one more question. There's some medical kind of questions. Two questions we'll take. One, family history of longevity, should that enter into the decision process of treatment, no treatment, prostatectomy? There's somebody who had a personal experience where they were told no. I would disagree about that, but more importantly is how the patient is doing, maybe more than their family history. And then the second question is something about proton therapy, and maybe we'll have Dr. Deville just comment on proton therapy for prostate cancer. But does someone want to take the longevity or family history of longevity?
Well, I think you answered it, Mo. 80 is the new 60, 70 is the new 50. We absolutely take into account folks' longevity and their family history. If everybody in somebody's family lived into the 90s in good health, we need to know that. So I think that we can put that one away. We definitively do. Over to you for protons,
Kurt, maybe like a 30-second spiel on proton, and then we'll conclude.
Absolutely. That's what I was going to say. I'll try to be brief. I think, I get asked all the time and try not to be overly biased. Obviously, I'm a radiation oncologist with expertise in proton therapy, but, we try to have equipoise. And I think, we're still learning very much about, proton therapy and what would be the true benefits. Specifically for prostate cancer, there's 2 national trials that are ongoing comparing protons and photons in a head-to-head fashion. So I tell men the jury is still out. 5 to 10 years from now, we'll have some more definitive data. But in the meantime, we have some studies trying to really learn the benefit with protons. There's no exit dose. We can see in our plan that there's less radiation, scatter radiation dose to normal tissues outside of the prostate. But the reality is we don't know if that really translates to less side effects. And that's what we sort of have to prove. And it may be that, not all men are served or all types of prostate cancer are served by protons. And it may be certain scenarios where we can really tease out a benefit. And that's kind of the era we're in terms of trying to define that.
Great, thank you. 2 quick questions. Rheumatology and other specialties, I can answer it. When there's a core group of people, specialties who are sort of regular on the tumor board circuit, but when there are patients who have complex issues requiring other specialties, we do invite them to the tumor board. And I've certainly seen almost any specialty attend in when it's relevant. And then does the Tumor Board issue a written report? All of the Tumor Board recommendations go into the medical record and are now accessible to patients as well. So, what an amazing set of case presentations and discussion. Thank you to Dr. Patel, who I understand had to leave to the airport. Hopefully he has a safe flight. And for the rest of my colleagues for taking the time and to share their expertise and passions with our audience through this unique experience. We will be sure to add the recording of this session to our website in the coming days. And a big thank you to all of you, our friends who joined this webinar, and for your continued support of the Brady and Johns Hopkins Medicine. Without you, our work would not be as impactful and meaningful, and our advances in clinical care are informed by and improved by the scientific research, philanthropy. And if you have any questions on how you can support our work, please reach out to the email address or phone number listed on the screen. Finally, if you enjoyed today's learning, please consider joining us for our future sessions in the series. Our next one is scheduled for Thursday, March 3, and will focus on bladder and kidney stone treatment and prevention. And thank you again for spending time with us, to the panelists, our attendees. I hope everybody has a wonderful holiday season, a healthy new year, and please stay safe, and we hope to see you soon.